And we move on to the next talk from Laura Daza. She's a postdoctoral researcher at Helmholtz Munich's Institute of Machine Learning for Biomedical Imaging and the Institute for Computational Imaging and AI in Medicine at TUM, led by Julia Schnabel. Her work focuses on foundation models and multimodal learning, integrating diverse data sources to improve understanding of medical images. Really looking forward to your talk.
Thank you very much. Hello, everyone. So today I'm going to talk about tactic. But before getting into the details, I want to first talk about these type of images, whole body MRIs, which is the images that we focus on, because they have several advantages. For example, you can look at systemic or multi-site pathologies at the same time in these type of images, which make them potentially better for screening because we can see pretty much the entire body at the same time. Because we're talking about MRI, we have excellent soft tissue contrast and no iodizing radiation. And well, most importantly for us in this area is that in the UK Biobank, we have access to thousands of these type of images. There are, of course, some disadvantages to it as well. For example, is the fact that since they are so huge, they also sacrifice some resolution, which makes it more difficult to find smaller localized structures. And because they also are so big, and it's not only big, but they have multiple modalities, they are very difficult to annotate and itself to analyze because they just contain way too much information. But with these images, we have some potential applications, for example, diabetes, in which you need to analyze the ratio of the fat distribution in the body, or you can target more localized diseases, like, for example, chronic obstructive pulmonary diseases. You could use it for oncology applications, also localized targets, or more general targets still in oncology, like metastasis, which is a task in which we are particularly interested. And of course, there are many, many other applications. But in this work, we focus on those 5. And what we did was that first, we took our whole body MRI set, and we divided it in train, validation, and test. But the amount of images of patients with these diseases are very small. So from the training set, we also extracted balanced subsets, where we selected all of the patients that had positive diagnosis for each of these diseases, and then we randomly also sampled healthy patients, making sure to preserve the sex ratio, the sex distribution. And now with this information, we can also actually use some extra data that the UK Biobank contains, which is clinical data from the patients. We know stuff about, for example, physical measurements, lifestyle variables, some laboratory results, and they are very important because they give us a fuller picture of the health of each individual patient. So we can see them as tabular data. The problem about these type of data is that you never know what information you will contain because it's very incomplete. You never know which patients had, for example, blood tests and which others had just urine test. So taking these both sources of information that we have, we ask these questions like, can we use whole body MRIs and complement them with the patient's clinical data for disease diagnosis? And the way we did this was, well, first, we selected 2 independent backbones encoders for each type of data. And for the imaging data, we had to do some modifications to this backbone because same as most 3D imaging backbones, they are not designed to take these type of massive images. Typically, you just extract patches from the images. But here, since we want to do classification and we want to look at the entire person at the same time, we had to adapt them by first adding some patch merging strategy to reduce the number of tokens that the transformer receives, and also taking it to advantage one characteristic of these images, and it's the fact that always around 40% of more of the tokens in these images contain only background. So we are always eliminating them, which gives us the advantage of reducing noise and also reducing the computational burden. So now that we have this, we pre-trained our imaging backbone using mask autoencoding, standard pre-training strategy with 90% masking, and TART is an established tabular foundation model. So from that one, we use the pre-trained publicly available weights. And yeah, when we do downstream fine-tuning, we train each independent encoder for each one of the tasks. And when we try to fuse them, we keep TART frozen. This is mainly for optimization stability. So the way we fuse them is actually quite simple, because we decided to take this not as multimodal data, but more like turning our tabular attributes into prompts. So we extract the feature representation of each attribute independently, and then we simulate data missingness by creating random subsets of attributes. As I said at the beginning, we never know what type of data we will obtain from each patient. It's very likely that it will be incomplete, but we want our model to be robust to this missingness. So we create random subsets. To each one of them, we concatenate an output token, and then we just perform simple self-attention and cross-attention between both data sources, which looks kind of like this. And after that, we can calculate the standard cross-entropy loss with each one of the subsets. However, there is another possible case that we could face, which is the total absence of clinical tabular data. So we also simulate that one by just giving an empty set of prompts, and we calculate an image loss. And based on the multimodal fusion literature, we also applied this more versus fewer loss that encourages the model to always obtain a higher performance when we have more modalities available. So in the end, we have these three losses, and that's how we optimize our full pipeline. And these are the results we obtain. So just to summarize this big table, we observe first that tactic is the only method that consistently improves over the image-only baseline. The reason why this happens is because we evaluated these methods under different scenarios with different amounts of tabular data availability. And what happened with most of our other methods that we compared is that when we have very little data, they start performing even worse than if you never give them tabular data at all, because they become reliant, they require that full set of tabular attributes. We also saw that in most cases, tactic also surpasses the clinical-only baseline, the clinical data-only baseline. Typically, using only the tabular attributes gives us a better performance, and even if the method manages to surpass the image-only baseline, they kind of stay behind the only tabular data. However, with our method, we managed to actually complement both sources of information to push the performance further. And some specific things we see about our task is that, unfortunately, diagnosing cancer is very, very difficult. We believe one of the reasons for this is that we chose breast and prostate cancer because they are very common. However, they are also very small targets. And we are talking about images that don't exactly have the highest resolution, so it's possible that we cannot see them all. There is also a little drawback with the imaging backbones that by dealing with these huge images, we cannot maintain all of the resolution either. But still, even with this small disappointment, we realized that these methods are actually surprisingly good for metastasis. which is the task that we were most worried about because it's the most difficult one. And also something very interesting we saw here is that this is the only case in which using only clinical variables from the patients is worse than using the images, which we think is because when you see at the clinical history of someone who has cancer versus cancer plus metastasis, it's very difficult to tell them apart. So now when we combine these two difficult sources of information, the images actually give us, help us a lot finding these extra structures. And just to finish here, I wanted to also show the behavior of our model under different data availability scenarios. So here in the x-axis, we see the percentage of tabular data that we have available, and the purple line shows that tactic, our method, is above all of the others. Also, as I said at some point at the beginning, you can see that some methods actually drop in performance when you give them very, very little tabular data, but our method is robust to this missingness. And that's all. This is our lab, and in case you want to learn a bit more about our research, feel free to scan it.
Thanks a lot. We have time for at least one question. Is there a question? Over there.
Hi. My question would be, because I know that metastasis is very hard, and it's specifically hard for clinicians to know the extent of it, and you said that this makes it easier, and I'm sorry, but I didn't fully understand that. How did you reach that conclusion?
So what we have observed, well, first of all, we know that metastases are incredibly difficult to find. That is why we are trying to focus on them. And we observed that using only the clinical information that we have from the patients, the one that we extract from the tabular data, it is not that easy for the models to identify whether a cancer patient will develop a metastasis. However, we managed to increase the performance by showing the method the whole body image. The metastasis can be anywhere in the body, and apparently this is capable of finding it easier than just giving it the clinical data. Again, we think that it's because when we just analyze the clinical attributes of a patient with cancer and a patient with cancer plus metastasis, they must be very similar.
Thank you.
We would have time for another quick one. Don't see anybody. Over there.
Thank you so much for the talk. I was wondering, so in this case scenario, for instance, a hospital would rather make a full body image of a patient with cancer to go and see directly if there's metastasis, and then the tool could recognize them. Do you think it's on the clinical practice? Is it something that is feasible and it's more convenient also for in terms of labor and so on and machinery for the hospital to just make the full body scan rather than any other usual practice that is used now?
So that is a great question, thank you, and that is something that we would hope for. However, unfortunately, whole body MRIs are not the common practice. This is why we are doing this exploratory research to see if we can properly use them. And as I said, metastasis is our particular focus, and we want to see if, at least for this specific case, they could be of help, because most of the cancer deaths come from metastasis development, so it's very important that we try our best to improve any way of diagnosis.
All right, thanks a lot. Let's thank Laura again.
Thank you very much.